Thanks for joining us here today. I'm Mark Geary, Head of Communications at Beaumont Health. Thanks for joining us today. We have with us Dr. Nick Gilpin, who is our Medical Director of Infection Prevention and Epidemiology, and also our Chief Nursing Officer, Susan Grant. We're going to start with Dr. Gilpin. He'll then turn it over to Susan. And then after Susan is done speaking, we'll welcome your questions and I'll call on reporters and they will answer your questions. So I will turn it on over to Dr. Gilpin.
Thanks, Mark. Good morning, everybody. As Mark said, I'm Dr. Nick Gilpin. I'm an infectious disease physician, and I'm also the Medical Director of Infection Prevention for Beaumont Health. And what I'm going to do today is give you a little bit of a situation update of where we stand with COVID in our hospitals for the first part. And then for the second part, I'm framing this as a community call to action of what things we can do to help flatten this curve and get us to a better place. It's been a little over a year since we had our first press conference where we talked about our first coronavirus death. And I, like many of you, was hoping that we would be on a better side of this by now, but alas, here we are. This is really the third surge that we're experiencing in southeastern Michigan. This is the fourth surge that the country has experienced, our first being back in March and April of 20. We had a brief respite in the summertime of last year, owing mostly to warm weather and restrictions that were put in place at that time to help keep the curve flat. Other parts of the country had some coronavirus activity at that time, but we were fairly fortunate to have low volumes. Then our coronavirus activity spiked up in the fall and the winter months from about November until January. At that time, we were caring for more than 700 patients in our 8-hospital system. And then we got a little bit of a break in the month of February, which has led to where we currently are in our third surge, which is just like a runaway train right now. And just to put that into perspective for you, we have over 800 patients with coronavirus in our 8-hospital system. This is really taxing our staff and our resources. I'm happy to sit before you today and let you know that we have enough PPE. We have enough ventilators. We're not strained in that sort of way, but we are strained from a staffing perspective. That is by far and away our biggest challenge. And so our strategy at this time to get to the other side of this pandemic and to flatten this curve is really about making sure we're getting as many people vaccinated as quickly as possible. And we do know that the vaccine is working. We do know that this vaccine is safe and effective, but there are many more people who need to get vaccinated. As of the last numbers I saw, about 40% of residents in the state of Michigan over age 16 have gotten at least one dose of the vaccine, and about 25% are fully vaccinated. That's a good start, but clearly we've got a long way to go to getting additional people vaccinated. We're seeing in our hospitals younger patients, by and large, a slightly younger demographic. And that makes sense when you think about it because we've done a very good job of vaccinating some of the older individuals over 65, and such. And so what we're doing is we're shifting that more vulnerable demographic to a slightly younger age. So we are seeing a younger patient population. And along with that, we're not seeing necessarily as severe of disease overall, but don't mistake that for the fact that we're seeing less severe disease. We're still absolutely seeing incredibly sick patients. Our emergency centers and our COVID units are filling up once again. And as I mentioned earlier, this is putting a lot of strain on our staff, which is our most precious resource. And so I guess with that, I want to pivot to the call to action part of this, which is what can you do? What can the public do to help us flatten this curve and help us get beyond this? Well, I think for starters, the public, we're not nurses. We're not all physicians. We can't all run to the hospitals to provide aid for these patients, but we can do simple things. No one can do everything, but everyone can do something. And something could be as simple as just wearing a mask, or just staying home when you're sick, or getting tested when you're sick. Or I would even say more importantly than those things, making sure you're getting vaccinated as quickly as possible, as soon as you're eligible to do so. And for people that are watching this right now, we all know people in our lives who are doubters or who don't feel that coronavirus is a severe illness, or that the consequences may not be severe, particularly if we're young. And I think we need to rewrite that thinking because frankly, I have had the unfortunate opportunity to care for a number of very young patients without significant medical conditions who have struggled with COVID. Many of them are suffering consequences well into their illness, upwards of 10 or 12 weeks, what we call so-called long COVID. And I just worry that we're so upside down in terms of our thinking about this, that it would be better to get COVID than to get a COVID vaccine. And I think that is just completely the wrong way to go about this. I really think we need to have those conversations with those people around us and really encourage people to get vaccinated because the vaccine absolutely does work. And the last thing I want to say before I pass it to our Chief Nursing Officer, Susan Grant, is that our staff are very tired and they appreciate the outpouring of support that the community has given us, the physicians, the nurses, the healthcare providers. We're very thankful to the community for being there for us and for rooting for us. But I think what they appreciate even more than the show of support in the community is that they just want this to be over. And so we really just want the community to do everything that they can do to help us get these numbers down so that our hospitals don't become overwhelmed and our staff don't become overwhelmed, and we can continue to do the things that we love to do, caring for our communities and providing necessary care for our patients. And with that, I'd like to turn it over to our Beaumont Health Chief Nursing Officer, Susan Grant, and then I suspect we'll both have an opportunity to take some questions.
Thank you, Dr. Gilpin, and good morning, everyone. As Dr. Gilpin said, I am Susan Grant. I am the Beaumont Health Chief Nursing Officer. And I just want to start by saying how proud and incredibly inspired I am by my nursing colleagues and by our team here across our hospitals at Beaumont, who have been so incredibly dedicated and committed to being present and being here for the people who need them. And they have never wavered once. They keep doing it every day. But I have to say that, last year, at this time last year, none of us would have imagined going through that extraordinarily difficult time that we would be here again, same time this year, and that we would be working and seeing so many patients who are infected with the coronavirus, hundreds and hundreds of them coming through our emergency rooms, being admitted to our hospitals and our intensive care units. None of us would have imagined that we would have been here again. And it's hard this year because now, after having done this for over a year now, our nurses, our doctors, respiratory therapists, our teams, they're tired and they're worn. And they're not only physically tired and worn, they're emotionally tired and worn. And as Dr. Gilpin said, they want this to go away. But that emotional exhaustion has come from experiencing and being present for observing the enormous toll that this virus has taken on patients, on families, on their own personal lives. They have seen a lot of death over the last year. And now they are experiencing and seeing younger people who are in our ICU beds, who are very, very sick, who are in the emergency rooms, in our hospital beds, who are very sick, and some who are dying. In talking with some of our nurses, someone just yesterday said to me, I was asking her, what can we do? How can we help? What do we need? What else do we need to do to get through this? And her response was, we're nurses. we'll get through this. We will do this. We will be here for our patients and their families, and we will care for them. But what is so incredibly difficult is seeing how young people are who are coming in now, and that they are saddened. The nurses are saddened, and our teams are saddened and heartbroken by the loss and the toll this is continuing to take on young people, on families, and on everyone. So one thing that we had experienced last year, and it's a vivid memory in my mind, was that last year we were so inspired and strengthened by the support of our community. Our community was incredible. And it was not only the outpouring of love and support that they showed us and just encouragement and just knowing that they were there, but we also knew too that they were working so hard in doing their part. And so we ask, and I joined Dr. Gilpin in his plea and call to action to the community is to don't leave us now. Stick with us and continue to do your part, continue to wear your mask, get your vaccine when you're able to, maintain that social distancing, hand washing, all those things we've all learned so much about over this past year that we know will work so that we can flatten this curve and see that happen again and get through this faster if we all stick together and do this together. So with that, I'll turn it back over to Mark.
All right, thank you very much, Susan and Dr. Gilpin. We really appreciate the words and what you all just shared with everyone. Just want to let everyone know that we will have a recording available afterwards. And right now, if you'd just like to raise your hand, I'll just call on reporters who have their hands raised. Looks like Rod Maloney, go ahead.
Yes, good morning. I have kind of a two-part question that sort of gets to the heart of this, doctor, and also the nursing representative there, Susan. The CDC is saying that we cannot vaccinate our way out of this, that it's going to take 6 weeks for the vaccine to matter. And there is the then issue of the governor not shutting down as she has previously. Do you agree with the CDC, number one, about vaccinations? Two, should the state be shutting down the way it has previously? And if not, what is then the solution?
Thanks for the question, Rod. It's a really important question. I want to say that I do agree with the CDC director that it is going to be difficult to vaccinate our way out of this. As I shared earlier, about 25% of our population is fully vaccinated. That's a far cry from where we need to be to get those herd immunity numbers that will really bring this under control. And as she pointed out, it does take 6 weeks for the vaccine to, in some cases, for the vaccine to reach full efficacy, right? If you have a 2-dose vaccine like Moderna that you're given 28 days apart, you will not have the full benefit of that vaccine protection for 6 weeks. 6 weeks is a long time. And especially when you're in the middle of a surging pandemic, that is frankly too long to wait for some of us that are working in these hospitals. So I applaud the efforts to get people vaccinated as quickly as possible. I think that's important. But if you also look back at our prior surges, what was the difference? The difference in the first surge that we experienced was that there were restrictions in the community to limit gathering sizes and limit indoor activities that we know are very effective ways to transmit coronavirus. We saw it in March and April of last year. We saw it in the fall and winter months in Michigan. And both of those surges, I believe, were curbed in part because of active restrictions. And I think that to your question, Rod, yes, I do think that we have to have some level of commitment to restrict some of those activities in the community. Now, I'm also aware that the governor has made a very strong statement that or a strong recommendation that people take it upon themselves to restrict themselves. And I think that the people who who are going to do the right things are already doing the right things. And the people who are not doing the right things will not do the right things. And so I think some of that is preaching to the choir, unfortunately. And in a time like this right now in Southeast Michigan and in Michigan at large, I do think we have to be a little bit more prescriptive, frankly.
Thank you, Dr. Gilpin. We'll go to Kristin Seamus from the Free Press.
Thanks so much for doing this with us today, and thanks for taking my question. I wanted to ask, how is the health system managing this volume of patients with current staffing, and are non-urgent procedures being postponed, or are you having to make some hard choices right now because of what you're facing?
Let me take the part about procedures, Kristin, and then I'll let Susan speak to the staffing component because she's been very much involved with that. With regard to procedures, we have held the line as much as possible on not canceling necessary surgical procedures. This really mirrors what we tried to accomplish in our prior surges. If someone has, say, cancer and they need surgery to remove their cancer, we do not want to postpone those surgeries. But at the same time, we have to look at certain surgical procedures that are done on a more elective basis that may not be of an urgent matter that we could potentially postpone right now. And that's what many of our hospital campuses are doing. So for example, if someone has a scheduled elective knee reconstruction or a knee replacement, that oftentimes those patients are required to stay in the hospital for a couple of days after surgery. Well, if our hospital capacity is such that putting someone in the hospital for a couple of days for an elective surgery is going to challenge our staff, we would rather postpone that surgery than proceed. And we're looking at each and every one of these situations really on a case-by-case basis, which is incredibly resource intensive, but we feel that's the right thing to do. Many healthcare systems have canceled elective surgeries outright. We're trying not to do that. We're trying to take this sort of balanced approach to looking at every surgery on a case-by-case basis and make those decisions. And I'll let Susan speak to the staffing component.
Sure. Thank you, Dr. Gilpin. So I think one thing for everyone to be aware of that in addition to this surge, remember that we also have this enormous vaccination clinic that we have in play that has been extremely successful and we're very proud of in the number of people we've been able to vaccinate. And we feel that's our role in our community to serve our community. Simultaneously, now we have this enormous surge that we're seeing. And so we have done a number of things to create staffing options and solutions to make sure we meet the needs of the patients. We have a number of our folks who are, first of all, they're very committed, as I said earlier, and dedicated. And so they are working extra. They're picking up extra shifts. They're working different times that they don't normally work. They're leaving their families at home and doing what they need to do to make sure our patients get what they need. In addition to that, though, because they are tired and we don't want to overexhaust people, we have reached out to external agencies to bring in supplemental staffing to help us with that, with our vaccine clinics, but also to deal with the surge. We've looked across the system, and we did this last year as well, to individuals who are not typically in the clinical setting, and we've redeployed them and reassigned them appropriately according to what they can and can't do and how they can support the floors in different ways and the inpatient units in different ways. We've had our advanced practice providers, who have taken on different roles to support our clinical teams as well. So it literally is an all hands on deck, and people are willing to step up and do what they need to do. But we need help. We need to know that everybody's doing their part and really helping to get us through this and to flatten this surge.
Thank you, Susan. We'll go next to Jordan.
Hi, thank you for taking my question. I've heard that the idea behind this surge is individuals are saying that it's natural and kind of expected because of the fact that Michigan shut down earlier in the pandemic. So our populace didn't get as sick last year. So this is just us catching up to the rest of the country. And I was wondering if you would agree with that type of reading of this current surge. And then I did have another question after that, but just that one to start.
Well, I'll take a swing at it. I think you have to look at this in a few buckets. One is, what's going on in the community that's driving transmission. We know that this this surge is being driven largely by a younger demographic, an unvaccinated demographic, who are doing more things in the community that will propagate the virus, gathering together in large groups, spending more time indoors, visiting bars and restaurants. We know all of those things will drive transmission. We also know that there are virus-specific variables here. Like, for example, we have a very large percentage of the B.1.1.7 UK variant, which we know is more transmissible. And another third variable that I would throw in there for consideration is an environmental one, and that is the weather. In Michigan right now, even though this is warm weather for us, and we enjoy this weather, it still is conducive to more indoor activities than outdoor activities. And so people are continuing to gather indoors. And the cooler weather and the somewhat drier air is better for this virus to move around. So when you look at Michigan and you say, well, why is Michigan surging, but Florida doesn't seem as bad? Well, Florida has B.1.1.7, and we certainly know Florida is open, but they also have a warmer climate, and it's more apt for people to be able to do activities outdoors, which we know are safer. You look at Michigan and you look at Texas and you say, well, why is Michigan surging, but Texas isn't surging? Texas is wide open. Well, Michigan has a greater proportion of B.1.1.7 compared with Texas. And we know that this variant is more transmissible. So when you look at all those variables, I think it's a bit of a perfect storm to explain why Michigan is where they are right now. And hopefully that, again, our strategy is to vaccinate as quickly as possible, and hopefully the community will do their part to limit this as well.
And then just to my second question, the governor doesn't seem like she's going to budge, at least currently, on shutting down. I mean, what do you see then as the worst case scenario due to that idea that it's time for people just to take personal responsibility? I mean, do you foresee, I don't know, something happening to the point where the governor will be basically forced to shut down if hospitals surge to capacity?
I don't know. and I also just want to punctuate that I'm frankly kind of happy that I don't have her job. I think, she has a very incredibly difficult job right now to manage, the sort of radioactive political environment that we're all existing in right now. So I'm going to leave those decisions to the governor. I've made it clear what I think is going to help this current surge that we're in and help us get to the other side. And I think those are the things we have to focus on.
All right. Thank you, Dr. Gilpin. Let's go to Caroline.
Hi, thanks so much for taking my question. The governor announced yesterday that she has plans to expand monoclonal antibody therapy. At Beaumont, do you guys have, at any of your campuses, do you have plans to sort of start doing more of that? And then just kind of a second part, a lot of hospitals in more rural areas like the Thumb are getting kind of full as well. And I know that they transport patients to other hospitals that might have more capacity. Are you guys getting those kinds of requests, and are you able to accept those requests right now with how full you guys are?
Well, let me speak to the monoclonal antibody part, and then I'll let Susan tackle the issue of the transfers. So the monoclonal antibody, you're correct. We do have an infrastructure to deliver monoclonal antibodies to patients. It's a complicated process. There are a lot of logistical considerations. We actually have a team of infectious disease physicians and pharmacists that sort of deal with the logistics. And again, a lot of this is resource intensive. We're looking at these on a case-by-case basis, which takes time. And so the ramping up, I suspect, is something that we will do our best to accommodate, as we have for all of our potential monoclonal antibody recipients. But it's also a delicate balance of supply and demand. When monoclonal antibodies were first available to us, the demand was overwhelming and the supply was so tiny that we really could not accommodate all of those requests. So in order for us to do our share, we need to make sure that we have enough supply to deliver those medications to the community. And again, we've got a good team that's looking out for this, and I'm sure we'll do our very best to get these patients the treatment that they deserve.
And just to add to that, we do have 2 clinics right now that are focusing on the monoclonal antibody treatments. And but as Dr. Gilpin said, very resource intensive, and we're working really hard to try to figure out how to continue to be able to serve as many people as possible with that. In terms of transfers, excuse me, we have been in the position, and last spring also worked very closely with the area health systems to transfer patients who may need a different level of care, or because of overcrowding, to be able to share in that kind of load balancing, if you will, across the area. And those conversations are underway as we speak. Every day we are assessing whether or not, depending within our own system, we do move patients depending on what the volumes are, the patient volumes are at each hospital, and also have been in contact with other health systems who have reached out to provide support as well. So yes, that is a part of the operations of managing these very high volumes of patients.
Thank you, Susan and Dr. Gilpin. Looks like Rod, you have another question?
Yes, I just wanted to go back to the notion of young COVID patients. And we have been told all along that the young were not nearly as susceptible. And so can you talk a little bit about what we're seeing, how it kind of flies in the face of what we've been told previously, and sort of the debilitating impacts that now we're seeing on the young, and also as sort of a 1A, how is this affecting death rates at all? And is there concern behind that as well?
Right. So as I said, we are seeing a younger demographic of patients being admitted to our hospitals. I do have an opportunity to review this data on an ongoing basis. So when you look back at the surges of the fall and the prior surge, our average patient in the hospital was in their 60s, young 60s, maybe slightly older than 65 or so. And now with the vaccine more widely available, that age has driven down. And last I checked, I believe the average age of our hospitalized patients with COVID now is in the young 50s. Now, fortunately, these patients seem to be suffering a relatively milder illness, right? So lower acuity, less ICU care required, shorter length of stay, less mortality, less ventilator utilization. Those are all indicators pointing to the fact that there is a less severe disease here. But again, Rod, I want to point out that this is not true across the board. We still, as our numbers increase and we get over 800 patients, a small but significant proportion of those patients will require intensive care in our hospitals, ventilators, ICU care. I've had the pleasure of taking care of a nice woman at the hospital where I spend most of my clinical time. She's 49 years old. She's been on oxygen for 2 weeks, and she's really struggling with this. And that's a story that any one of our infectious disease doctors could tell you about any one of their patients. So we are seeing severe disease even in the younger population, even as young as children. And I know our pediatric infectious disease physicians have commented that when you start to see surges in communities where thousands and thousands of patients a day are coming down with COVID, you're going to have sick younger people in the mix. And that's exactly what we're seeing as well.
All right, thank you very much. We'll take a couple more questions here. So if you have a question, please raise your hand. But we're going to try to wind things down a bit. Kristin, you have a second question?
Thank you, Mark. I do. I read about triage tents going up at hospitals in other parts of the country that are facing surges. And I also recall refrigerated trucks being needed in the initial surge here in Michigan to handle all the bodies of the dead. I'm wondering, is Beaumont preparing for any of those things to kind of contribute to what you're doing right now, given that we're seeing such a big influx of patients needing hospitalization?
Always. We are always preparing for those things. We have a corporate incident command structure. It's very militaresque, frankly. And we have an opportunity to collaborate every single day with leaders from across our system, with people from logistics, nursing, physicians, hospital administrators, asking all of those questions. Where do we stand with space? Where do we stand with staffing? Where do we stand with PPE? And making sure we're getting in front of those issues as quickly as possible. To your question about setting up outdoor triaging stations, or what we call curbside, some of our hospitals have gone back to establishing a curbside triage center for some of the intake of these patients as they come to our emergency centers. Again, that's just to help sort of balance the load in our emergency centers. And as of right now, I'm not aware of any need for any external refrigerated vehicles or anything I believe our morgue capacity has been adequate at this point.
Could I ask you to please share which hospitals might have those emergency triage tents set up?
Well, I'm not sure which of the 8, maybe Susan knows that better. I will say the Beaumont Grosse Pointe Hospital that I spend the majority of my time at, we have recently opened up our outdoor curbside triaging. Susan, do you know of other sites?
As of this morning, I know that a number of our sites, Farmington Hills and Dearborn, had been considering doing that. I'm not sure if they've stood them up yet, but it's under active discussion. And to Dr. Gilpin's point around preparedness, in our command structure, we system-wide, all of our department leads, every single morning we come together in our emergency command center virtually across the system to constantly assess what the needs are across the system, from a supply standpoint to PPE to more capacity transfers, et cetera, so that we all are working on that continuously.
All right. Thank you. Kyle.
Yeah, thank you very much. My question is just if you guys could kind of put the numbers, quantify the numbers as far as what you're seeing at the hospital. Do you have that? I mean, are you like 90% capacity, 95% capacity? And how does that compare to the other surges? If you just kind of quantify that for me.
I'll do my best and I'll ask Susan to chime in. Most of our hospitals are floating very close to their hospital capacity. And again, part of that is because in addition to, we've got what I'll call our regular COVID business, right? And then we've got our COVID patients, which keep climbing up, and our regular business really hasn't slowed down considerably. So when you add those two variables together, it's expected that we're going to start to get close to our ceiling in terms of capacity. But with that in mind, it's tight. Every day, each of our sites meets very actively to see what they can do to create space. If patients are stable and can be safely discharged home, we have a very active process to try to move patients home. We want patients to be home. We feel like patients recover well at home, especially once they've gotten off of oxygen and they're improving. And so in that regard, we're tight, but we're not to the point where we've had to create additional beds or space or move patients to the lawn or set up anything, of that sort as of yet.
Yeah, I would just add to that, as Dr. Gilpin said, many of our hospitals right now, I think the difference between now and last year is that this year we have, the COVID patients, and then we also have our, additional, other people. And I think because people are out and about and doing what they're getting on with their lives, we're seeing kind of the normal flow that we typically see in the non-COVID population. So we have both of those groups of patients creating this high volume. But our COVID volume obviously is very, very high in each one of the hospitals. And I believe as of this morning, we were around 90 to 95% capacity in most of our hospitals. But we do look at different patient care areas, and our staff have become just experts at figuring out where we can take additional patients within the hospitals and open those areas or change those areas from one service to another to accommodate the needs of our patients.
Thank you.
All right, looks like we have two final questions. First from Jordan.
Yeah. So in the teaching profession, there is concern that because of the stress that COVID has caused, there will be an exodus of teachers. To Susan, perhaps, are you at all concerned that the same level of, I don't know, like nurses perhaps leaving the field due to the stress that this has caused in the constant time and commitment that's being asked right now during the virus? Are you at all concerned that maybe following this pandemic, there will be an exodus from the field?
We worry about it every day, and we are seeing it already, unfortunately. It's very concerning. We've had folks, and I know that nursing across the country has experienced this as well, where individuals may have been considering retirement 2 years from now or a year from now, and they've decided to go ahead and do it now because of the demands of caring for such high numbers of such very, very sick patients. So it is a real concern. It's something that we are working through. One of the things I think that has really surfaced to the top through this pandemic for not only nurses, but for healthcare providers in general is their well-being and their health and wellness, and how do we help to manage and create environments that they can thrive, that reduce burnout. And the pandemic has really highlighted that, I think, for all of us, that as Dr. Gilpin said earlier, these people are our most precious resource. And so our focus on wellness has become paramount as we've gone through this.
All right, thank you, Susan. And Rob, will go to you one more time for the final question.
Yeah, sorry to be so difficult here, but I would like to get back to the notion of the 800 patients. You've got 800 patients now. In the worst of the surge last year, what was that number then? And is there a threshold number where you get to that point where you begin to implement some of the things that we did see last year?
Yeah, so the difference today, Rod, at 800 patients strong, we're at about 90 to 95% capacity in our hospitals. The difference back then was we had, I believe, over 1,200, maybe close to 1,300 total COVID patients in our 8 hospital system. But at that time, if you recall, there was a massive silencing of all other patients in our hospitals. People did not want to come to our hospitals. They were afraid of COVID. They were ignoring other conditions because they were afraid of getting COVID. So if they had chest pain or abdominal pain, they weren't coming in. So our hospitals at that time were almost, in some cases, exclusively COVID hospitals. That has not been the case right now. So that's, I think, a key difference that's important to highlight here. If we continue to see COVID numbers rise, we'll have to make some accommodations. We can open up some additional beds. But again, the challenge here, and I think the theme of the day is, where are we going to get that staff from? We can manufacture beds. We can open up beds. We can create entire wings of the hospital if we have to. But if we don't have people to staff those beds, we got nothing.
All right, thank you so much, Dr. Gilpin and Susan, for sharing such great insight and perspective. Thank you all for joining us today, and we will make a recording available afterwards for everyone. Have a good day.
Thank you.